Good afternoon, everyone. It is our pleasure to welcome you to the Sudanese Society of Breast Imaging and Women Health October webinar titled Diagnosis and Management of Metastatic Breast Cancer. We are your moderators for today, Dr. Nadia Dawi and Dr. Wala myself, and we are proud to represent the Sudanese Society of Breast Imaging and Women Health under the Sudanese Association of Radiologists and the Sudan Medical Specialization Board. Despite the very real challenges our country continues to face, our collective commitment to education, professional development, and improving breast cancer care remains strong and undertaken. Beginning experts together from radiology, pathology, surgery, and medical oncology reflects our shared belief in the power of collaboration to serve our patients better. We thank you all for joining us from Sudan and around the world. We look forward to rich learning experience and active engagement from everyone. So now I will start with presenting our Professor Mohammed Al-Mu'tasim Abdelbagi for the first presentation, Imaging Evaluation of Metastatic Breast Cancer. Prof. Mohammed Al-Mu'tasim Abdelbagi, MBBS, DMRMD, Master FFRCS, FRCR Professor. Al-Mu'tasim is highly respected radiologist with extensive experience in breast imaging and oncology diagnostics. He has played a leading role in advancing imaging services and education in Sudan and continues to contribute effectively to regional clinical training and research. Prof. Al-Mu'tasim, the mic is yours. You can start presenting your rich presentation. Thank you very much.
Thank you very much for your kind words. And Bismillah ar-Rahman ar-Rahim wa salatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. أول شيء يعني the first thing I have to say في حق SSBIWH is that this is the most perseverant nucleus in our medical community of the Sudan. And it is the most active, the most scientific to the world, the most scientific, and also the most welcoming and embracing for the young, particularly if you have attended the last seminars. A lot of it were, a lot of them were young breeds for their first time. And that's what we used to lack before, you know, the big giants used to hold the show all the time. So I must testify to the greatness of this SSBIWH, and I wish them all the best in the future. And I wish other societies would equally compete or supersede your society so that our medical community will be enriched with ما ينفع الناس. طبعا لازم يعني نشكر القائمين على هذا العمل والقائمات على هذا إذا كان مجازي التأنيث. فأكيد رباب هي النحلة، هي الدينامو، هي أحيانا الواعظ، أحيانا المفتي. فما لا أريد أن أقسم ظهرها لكن that's true and we have to specify. كذلك زميلاتها أكيد لما بتجد تشجيع ومساعدة من زميلاتها she would have given up long time. معلش ما نطول خارج الموضوع. My topic is metastatic breast cancer. We all have to remember that metastases are bidirectional. If you talk about metastasis, lung metastasis, remember there are tumors going out of the lung and tumors coming into the lung. Again, طبعا في predominance of one direction to the other direction. You get more liver metastasis than primary liver sending metastasis to other regions. And in the breast, it is the other way around. You get breast cancer throwing away metastasis into different parts of the body and very few deposits will come from outside the breast as metastasis into the breast. And I have put in here the Blue Nile, and I think it's the Blue Nile has become now unidirectional metastasis. It's just throwing scientists and clinicians and أهلا الطيبين, throwing them out of the country. In the past, it used to be bi-directional. We have been abroad, we went back to the country, then we went abroad again, and then went back to the country. But unfortunately, the predominance is now is metastasis out of the country. I hope this is reversed soon. Now, I will cover these aspects. I've tried to be brief and short. Metastasis that occur before discovering the primary, any patients presenting with a pathologic fracture or metastasis elsewhere. We'll also go through common metastasis, the metastasis according to tumor type, and metastasis of rare sites. I will touch on synchronous and metachronous tumors, bilateral primary versus breast-to-breast metastasis, lymph nodes, and their impact on management. هذا يعني من مستصغر الشرر. These small nodes can change the line of management. And then we have metastasis mimickers in the liver and in the bones. Lymph nodes should be criticized critically, whether they are metastatic or not. It could be just functional lymph nodes. Follow-up and prognosis is important, and interventional techniques, of course, are taking over a lot of the management. Now, our journey between radiology and breast cancer is a lifelong journey. It's a continuous long journey. We start with breast tumors and breast cancer from the screening level, or when they are symptomatic, from symptomatic clinics or walk-in clinics, right? We start there with radiology. It goes on, our pathologists come in and tell us about the tissue typing, okay? And then when we go towards forwards, the surgeons will come in with what they want to say, whether it's resectable or not, whether there is indication or contraindication to surgery. So we're again there. Oncologists, they want a full screening of the whole patients from head to toe, okay? And then again, we are called into action. Plastic surgeons, they want fine details about whether they can use the pectoralis major or they use the latissimus dorsi or whatever. Again, we have to go back and revise the images and look at soft tissue components to tell them. If you go to palliative care, okay, they will need like a supportive imaging, pneumonias, and the other complications for late presenting cases. طبعا, the good news will come if we could confirm that the tumor was cured, the metastases have resolved. Okay, and the bad news if we tell them that there is recurrence. So radiology goes all the way, all the journey, like the Nile. And I'm homesick, like most of you. That's why I use things referring to the home country. And sometimes I say, like, طبعا هنا mature community. When I'm doing students abroad here, and tomorrow I'm doing Khartoum University students, some of them are born outside the country. So I show them what the Sudan looks like. And I have to give names of the rivers. They might not know it. So the journey here can start. Can you see the pointer? No?
Yes, we can see the pointer.
You can see the pointer. So the journey starts from discovering a nasty tumor like that, okay, by ultrasound or by mammography. And then we follow treatment and therapy. This is preoperative, this is postoperative, this is 20 months later. And that's the good news when we confirm that the tumor was successfully resected and the tumor margins on the specimen were all surrounded by healthy tissue. Now, what I'm not going to spend time on is the recurrence, the local recurrence, although it's part of the dilemma itself. But if you write, you can read a lot. There are a lot of this in the literature, or sometime we can make a separate topic. Now, the first thing about metastasis is those presenting before the primary is known. And the most famous is the pathologic lesions in the bones. Either they come with bone swelling or they come with pathologic fracture, okay, whether it's lucent lines or sclerotic deposits. Again, they come before the patient knows that she has a breast lump. And very strange sometimes, and very terrible is that this patient this is this paper, it's not my cases, presented with intramedullary metastasis. The whole cord is gone. Patient cannot walk anymore with this one. And that's a very late stage. This patient, if you can read in here, she's presented with gastric problems, etc., 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 and abdominal pain and abdominal distension and ascites. They were investigating all those. And finally, it proved to be this small carcinoma of the breast. So presentation can be by metastasis first before they know that there is a primary. But the common...
Sorry, Prof, for interruption. Regarding the case of GI, do you remember it was lobular or you don't remember?
I don't
Is it
recall, but
lobular?
that's the
That's okay.
that's
Okay.
the reference you can check.
Okay, we'll see
Okay.
it.
You can check while we are going on now and tell us about it, because that's again adding information. Okay. Now, if we go to the common metastases that you would usually see during imaging, lungs, of course, very favorite site, bones, spine is the favorite site. And we always, when looking at CT, people should not forget to put in the bone window and look at the spine, because it may be the only site. The other thing that you can see is of course, the lungs and chest X-rays or on CTs, etc. Ribs, we should always look at the ribs. It's easier, طبعا, when you do functional imaging with PET or isotopes, but sometimes on CT, people do not look at the ribs or don't look at the spine. This is a solitary metastasis. If you are not careful, you will not see it. Let me take this out of the way. Oops. It's gone. Sorry about that. I wanted to remove the images. Back to sharing. Sharing has stopped. Okay.
No problem. Take it.
Share. I tried to remove our photos, and then I are screen sharing now. جيك حلعة ما مشكلة. Yeah, I'm sharing the screen. So where is it? Where?
You open the presentation again.
It is chance في المدة دي عشان أصور الريفرنس أشوفه لك. أنا حكت قبل صورت.
It was lobular. Yes, it's clearly written there. Primary lobular cancer.
Lobular? Yes, expected.
How can I find my slides? It says here you are sharing the screen.
Make search up. Search about the metastatic or metastasis. You'll find it.
Search Iowa.
Yes.
The top of your screen there is a Zoom meeting.
There is Zoom.
Oh, he's looking for the PowerPoint itself. Yes.
Yes.
Yeah.
You see it now?
Yes.
Yes.
Okay, now I don't touch anything anymore. Okay. So
Just make it bigger from the cup down. Yeah, Prof. Yes. The other one.
the other one sometimes يعلق كده. فالثاني I'm not taking risks. Okay. Now these are the common sites that you all know كده. Remember the liver is a very
البروف طلع برا.
okay. What's that? I'm getting a double. Okay. We see now more of adrenal metastasis than before. I don't know why.
يا بروف
لكن whenever we
unshared. You are unshared now. تاني طلعت.
سبحان الله.
إذا عاوزناه شير
Okay.
لك أنا ممكن أشير.
Share, yes. Share from your side.
خلاص كويس.
That's why I sent it all, Gibel.
أيوة أحسن. خلاص شير لك الآن.
I close this.
انت اصلا طلعت بس خليك كده. خليك يا بروف. لو كلوزد هتقفل كاميرتك انت. فخليك.
Nice. طيب.
شايفين الشاشة؟
ايوه شايف يلا زوم اب.
كده شايفين؟
شايفين
أنا؟
لكن ما شير سكرين.
كبيرة.
ما خدتها كبيرة.
أوكي شيرت بالجهة الثانية. هطلع من الشير وأعمل شير ثاني. end slide.
ما هي سلايد شو.
أوكي أخليها هنا. أحاول أشير. أو ذات
ايوه بس كبيرة.
هي كده مشيرة ولا أنا غلطانة؟
صغيرة.
أوكي
make it bigger.
أشيرها من الجهاز ده أحسن. هي كده عاملة أكبر حاجة. طيب أحاول تاني. كده كيف؟ نو؟
ما زالت صغيرة كده.
طيب نشيرها بالشاشة بتاعتكم انتوا. شير. كده كبيرة؟ نو؟
Yes.
أوكي
For me this is good enough.
أوكي and you all؟
yes.
تمام.
شكرا. Next. Next. Please. Next.
تقريبا.
Please. Yes, I stopped here. I was saying that when we look at metastasis, we have to decide whether it's oligo, solitary, or less than 3, or in was the same region. So, and whether these are multiple or dispersed, because that affects the surgical management, as we will hear later on from Mr. Hussein. Next. Now, metastasis, when we look at metastasis, there are classic sites that we have to see. لكن certain tumors prefer certain areas in the body. And that's very important because of, personalized care. And you get somebody who cannot afford to have a PET CT, okay, which will show him everything in the body. He cannot afford to have brain MRI, cervical MRI, chest MRI, like that. So we try to choose. Yeah, and if somebody comes with a triple negative, I must include the brain on the scan. And likewise, if you go, you find the preference of certain disease. If you are limiting your imaging, you go to the favorite area of choice. Next. And these are examples of different tumors, like the lumen and HER2. Our pathologists will tell us more about these things. The liver, of course, everybody goes to the liver and everybody goes to the lungs, right? But there's some preference for the brains and the distant lymph nodes, the luminal type. And as you say, like you've seen in the last case, the lobular could go to GIT. Next, please. Okay. Now, problem is when you get lesions in both breasts. are these primaries? Is this metastasis from one to the other, or are they both metastasis from a distant source? And I wish Tertil was here. She gave an excellent presentation, and I tried not to cover that topic because she did very well with the metastasis into the breast. It showed us every organ was sending to the breast. Even I asked her, let us know which tumor does not go to the breast, rather than which tumor goes to the breast. Next, please. Now, distant primaries are variable. You can say from lung, melanoma, lymphoma, uterine carcinoma, again, bidirectional. These can go there, this can go back. Melanoma comes here from the skin. Breast cancer sends metastasis to the skin, as you can see. Next. These are the unusual metastases. You can see in the middle here, this is the skin metastasis, very unusual. But these are, I always give you the reference because these are not my cases. I'm doing review. So here is an example, okay? And here is an example of the tumor presenting as gastric upset and gastritis, etc., etc. And here is the ultrasound, okay, endogenous ultrasound, and this is the CT, and there's the images there from breast. Even metastasis can go to the pancreas. The pancreas can send to the breast. The orbits is no exemption, and sphenoid bone is no exemption. Okay, next, please. Other rare sites, the brain, as we already mentioned, which tumor prefers the brain, the triple negative. You can get the rare type of leptomeningeal metastasis. These are very difficult to treat, very unfortunate. They are affecting the meninges and they permeate between the sulci and gyri. Okay, and you can see this is very aggressive type. They can be dural, thick dural, or they can be just like just pachymeningeal enhancement. Okay, a very alarming extension of these metastases. Other rare things like this is a finger with a metastasis. This طبعا distal in the hands. These are commonly from breast bronchial carcinoma, but the breast can even go there. Skull bones, yes. The pleura. Pleura is again a site, a rare site. They go more to the lungs than into the pleura itself, but it can go to the pleura. Next, please. Now, from the breast to the cervix uteri, to the ovaries, right? And this is example of the pancreas. So things are bidirectional. Next, please. This is one I showed you before, or showed a case similar to it, going to the spine. Next, please. Orbits. One lungs is the colonic site. Orbits. Okay, can get involved. Next. Now, when the two lumps occur in the breast, you want to know whether these are metachronous or synchronous. Metachronous, by definition, are those that occur shortly after the initial tumor or are the first primary tumor, like مثلا in this case, in 2012, a tumor was resected, okay? And then 2013, another tumor appeared in the other breast. Here, you have this phylloides taken away, then later on, after this was removed, something else came out as an invasive breast cancer on the other side. So these are metachronous, not at the same time. But next, please. You can have synchronous, and those cause a problem because there will be the question whether this one is metastasis into the other organ, but you have to rely on our pathologists to tell us is this kid. Actually, they proved مثلا that's the one on the irregular in the left, and then the other one is well-defined, mucinous type, etc. So they could tell us whether they are synchronous primary or one breast has sent metastasis to the other sister breast. Okay? Again, synchronous, not necessarily between the two breasts, between the breast and the kidney or other organ anywhere themselves. So these are synchronous and those were metachronous because these were discovered at the same time. Thank you. Next. Remember, there are occult metastases. They can be there. Our imaging may fail to show them, or our images may fail to see them. Either it's a limitation of equipment facilities, or it's a failure on our part. But it's very difficult. Even this one have had an isotope. Yeah, osteoarthritis, something. Oh, nobody cares. But if you do more sensitive PET, then you will see that this is a hot spot. On the CT, it was not impressive. So this is an occult type of lesions, which can be missed again and again if people are only doing this. And even here, we're famous about liver. Liver is the workhorse of radiology. It does not miss anything. Look here, it has missed all these metastases. Not only the liver, the conventional, and not only the CT, the conventional MRI, okay? Fat suppressed or not fat suppressed, contrast or not, did not detect these lesions. But now we have the $1 million tool in the brain and everywhere in the body, the diffusion weighted images. This is very, 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 very sensitive. Okay. And I hope one day we talk about the mechanism of this diffusion. So these are occult metastases or undetectable metastases at first glance. Next, please. Am I still within time?
Yes, Prof. We have time. Continue.
Thank you. Now, السهل الممتنع أو القشة التي تحصم ظهر البعير أو مستصغر الشرري هو الليمف nodes in case of breast cancer. They are the determinant of management. سبحان الله. يعني احنا نقول التيومر كبير ولا التيومر صغير ولا لا. الليمف nodes. Which lymph node is involved? That now they force people, الفقهاء زي ناس رباب وكده اضطروا to reclassify الليمف nodes بدل N1, N2, N3, N1, A, B, C, etc. etc. ليه؟ because they change the management. حتى تشوف يعني في this patient might not have any other lymph node and might have a small tumor. Okay, but once an internal memory or the supraclav is involved, this is 3C. خلاص انتهى الكلام. So lymph nodes is a trouble for us. We have to look at them very carefully. They are peripheral, okay? They are not central in the view. So you have to look carefully at them. With ultrasound, again, they demand very high skill to identify, and I will just talk a little bit about that, to identify which node is abnormal. And this is the anatomy طبعا of the lymph node chain, okay? The important marker is the pectoralis minor and the clavicle. Okay, so you look whether this is behind the muscle, hidden by the muscle, below the muscle, or above the muscle, even above the muscle and maybe above the clavicle itself, right? And then accordingly, you will get the classification. Next, please. The size of the lymph nodes, what size? We see everybody has about 300 to 500 lymph nodes in the body. And they react to skin abrasion, they react to skin infections, they react to all granulomas, all TB, everything, all sarcoid, etc. So which one of them matters in breast management? First, it's easy to judge by the size. If the size is less than 5 millimeters, we say this is probably benign and we may not follow it up. But if the size is between 0.5 centimeter and 2 centimeters, the risk of malignancy raises up to 20%. Above 2 centimeters, the risk is high, but actually, statistically, it's only 40%. But if you ask any imager, he will tell you, oh, above 2 centimeters, oh, this is definitely malignant. But it's not a scientific decision. So sometimes, and particularly those who attend MDT meetings with wise people, they will try to give the patient the benefit of the doubt. If he is doomed, okay, give some hope. Give some help to the patient. So exercise this wisdom. I have seen this. Some oncologists have got the smart attitude of giving the patient the benefit of the doubt, where it may not affect the management. Whereas somebody will open the book, page 19, I will say, okay, now this is that interesting. Next, please. And here we are. I'm not going into the classification that's covered during the course before, but just a reminder to ourselves. Next, please. Okay, lymph nodes again. Remember lymph nodes, please, and look at lymph nodes. طبعا easy if you have PET CT or if you have a good MRI. Mind you, some MRI techniques are not up to the level. Just MRI, basic thing, MRI. It's not like, imaging the knee or even imaging the brain. These are very easy sequences. But for the breast and to get the dynamic time intensity curve of enhancement, you have to have a good machine and you have to have dedicated staff, dedicated radiologists to do that for you. Next, please. And here we are. Ultrasound. Ultrasound طبعا is a very simple, safe, and cheap. And actually, all our or most of our work at home now اللي شباب المتطوعين والعايشين في الحرب وفي الدنج وفي التهديد وكده, they are relying on ultrasound. Therefore, I wanted to emphasize what is a normal lymph node and what is an abnormal lymph node. And the only absolute criteria that this is a malignant node, beside the vascularity or anything, is the absence of a hilum. When you don't see the hilum, then cholestatic. Other thing, you go to the vascularity, you go to the thickness of the cortex, and cortex should be more than 5 millimeters to call it, this is malignant. The shape, yes, the shape is good, but remember, if it has previous periadenitis from previous infections, the shape may be distorted a little bit. Next, please. Now, the last aspect is the role of the interventional radiologists, or the interventional techniques rather than interventional radiologists, because a lot of people are taking up interventional radiology because radiology is beautiful. So everybody wants it. So this is an example of the transarterial chemoembolization. And this, of course, yttrium now has changed the scene. But yttrium treatment for a patient would cost $30,000 US. But it has worked. It has killed multiple, show you examples later on, multiple metastases, particularly in the liver, which will change the quality of life for preservation. The worst thing for a patient is to be itching and scratching his skin from obstructive jaundice. It's easier when it's ducts are dilated, but when the liver cells are compressed by masses, then you have to get those masses to decrease in size. Next, please. So that's an example. Oh, this is just a reminder of breast metastasis from lung cancer, and we have seen a lot with Tertil from these. Next, please. Yes, next, please. Remember, endometrium can be the site of metastasis. Yes, well, therapy of my colleagues will be talking about that. Next, please. Again, just to remind, we have to say whether it's oligometastasis or these are multiple metastases, and whether it's oligoregional or whether widespread. One in the lung and one in the bone. Nowhere. Next, please. This is an example of radioembolization with the yttrium, the one I mentioned before, and how the liver was studied. It was all total invasion, and see on the follow-up. Fantastic. Maybe it's worth the money if the healthcare system can afford it. Next, please. Just to remind you, on the follow-up of tamoxifen patient is to look at the endometrium to see if there are any developing any complications there, because these patients come for follow-up as a part of their long-term follow-up. Next. Now, again, we talked about this. Next, please. Now, the other aspect is the mimickers of metastasis. And the commonest site to get confused is in the liver, because the liver is host to many lesions. Metastasis from other organs or lookalike metastasis. And we have to remember our country, in particular in these circumstances, that tuberculosis can look like metastasis. And we have seen cases like this. And I have seen a relative of mine who was told she has metastasis after she was cured from a triple negative. And when we did the biopsy here in Riyadh, it proved to be tuberculosis. She's now happy and living again in Riyadh, in another city here. Now, the other thing we should not be confused is hemangioma. Remember, hemangioma has got many presentations. Okay, it can be the classic peripherally nodular enhancement, filling later with time. They call it the centripetal type of filling, or the other type, which is a flash hemangioma, which enhances in the arterial phase, or the odd type, which looks like angry tumors. But with familiarity or with the combination of CT and MRI, one can easily sort this out. Other odd things in the liver is the focal fatty deposition or focal fatty sparing, whether single or multiple. And these are benign areas. Sometimes the whole liver has got a lot of fatty deposition, but there is one segment which has got a different blood supply from the inferior pancreatic draining vein, and that will not have fatty deposition. And the other way around, this might have an accessory vein from higher up, and the others are normal, etc. The mechanism is so complicated. I don't want to go into those details, but this can cause alarm, false alarm. The other thing is the common benign lesions in the liver, like the FNH, focal nodular hyperplasia, with its characteristic central skin. And the other is the adenoma. Adenoma, as you know, is common in ladies who are taking the pills, and they should be removed, actually. They should be removed because first, they are like very vascular. They can bleed from any minor. Now ladies are driving, okay? Seat belt injury can cause them to bleed. And the other thing, they are precancerous themselves. They have some percentage of conversion to carcinoma, hepatocellular carcinoma. Next, please. You can read more about this. Next, please, about the interventional part. And the management will be covered. Next, please. Now, these are just examples of cryoablation of the primary tumor itself. You can use freezing ice, nitrogen to ablate the tumors. You can use microwave ablation for the tumor or for the metastasis in the liver. Next, please. And you can read about these things again. The chemo, the intra-arterial chemo, again, can kill these lesions in the liver or elsewhere. through arterial catheters, or the radio. So it's either TACI or TERI. So either inject chemo, or inject radioactive material if you have the money. It's this. I think that now this is a repeat. Next. I think this may be the last. Same thing, same story. Next. Now, so finally, at the end of the journey, I told you we started from screening, and now we are hoping for cure rather than looking for recurrence or failure of treatment. And you have two examples here from the literature that you can look it up there, is that this advanced disease, okay? And then intramammary lump أكبر من التيومر نفسه. والintramammary, I told you, these are يعني crucial nodes for the prognosis. Again, treated, look at this, or practically cured. Metastasis, liver metastasis, very frightening, in December 2015, and this is a liver in 2021. And that's the references you can read. And look at this one, big lump there, phylloides or whatever. And then with time and patience, look at this, followed over 294 days, nearly a year. So look at the size has come to what. I'm sure our pathologists will teach us what does these slides mean. If there is no pathologist, I will explain it to the people. Like if the pathologist, I keep quiet. Nadia is present. Next, please. Next, is that the last one? Thank you very much. Thank you for listening. I look forward to the rest of the presentations.
Thank you very much, Professor Al-Muhtasim, for that outstanding presentation. Your depth of knowledge, clarity, and practical insights you shared have truly enriched our understanding of different methods of breast cancer. I'm sure everyone here has signed valuable perspectives that will inspire future discussions and practice. Thank you very much. Anyone want to add anything? Dr. Rabab?
As usual, we enjoy it. It's a time running very fast, as if it is 3 minutes, not 30 minutes. ما عارفة أقول شنو بصراحة. طبعا البروف محاضراته دايما شيقة لدرجة لدرجة مبالغ فيها وكل مرة بقول له علمنا الطريقة بتاعت البرزنتيشن دي حتى إنه نقدر نجذب الآخرين. عنده طريقة جذابة جدا جدا. Very attractive, very enjoyable. Thank you very much, Prof. For sharing with us these very insightful and amazing presentations. We cannot forget each word you have mentioned in this lecture. Thank you very much.
Thank you. You will do better, inshallah.
Inshallah.
So do you want me to go for the next speaker?
Dr. Nadia?
Okay.
Yes. Assalamu alaikum.
Wow.
We continue with the second lecture or talk, pathological aspects of metastatic breast cancer. It will be given by Dr. Jihan Ahmed Ibrahim. She is one of my students, and I love working with her. She did her pathology degree in Jordan. They do a four-year course in histopathology in Jordan. And she is affiliated to a Nilain Hospital, University. Jihan, تفضلي. I think you will give us a lovely talk.
Assalamu alaikum wa rahmatullah. يعني إضافة لكلام الدكتورة نادية، شكرا جزيلا أستاذي العزيزة دكتورة نادية.
أهلاً.
دكتورة رحاب، فعلا كلامك صح. يعني أنا بعد شفت البرزنتيشن بتاع بروف المعتصم يعني حسيت بإني حكون مملة شديد، فغايته ربنا يقدرني وأكون يعني كده يعني أقدر أقدم حاجة. لكن شكرا جزيلا بروف معتصم على very nice and very excellent presentation.
Jihana, I will set you as is. All of the attendees are looking forward to our pathology lectures. They want to learn pathology. They want to revise their pathology and
Yeah.
correlate with their
Sure,
findings.
sure. As Nadia said, we are waiting for your lectures. And inshallah, it will be grateful one. Don't worry.
Yes.
إدارة ما في مشكلة.
Yes, I assure you,
Each of
Dr.
you
Rehab.
has his own aspect, you see, of presentations. We'll enjoy it. I'm sure we'll enjoy it.
Everybody has his flavor.
Yeah, everyone has his flavor, yes.
تفضل
Go
يا
ahead.
جيهان.
Go ahead.
Do you want me to share or you can share? I will stop sharing. Yes. Lovely. We can't hear you, Jihan. Yes.
Okay, Assalamu alaikum. I hope you are hearing me.
Yes, we hear you.
Okay. I'm going to present some pathological aspects of metastatic breast carcinoma. Would be talking about general and essential feature, epidemiology, pathophysiology, sites for metastasis, briefly about diagnosis, and we'll touch just on treatment. Generally speaking, breast cancer, as we know, it is the highest, has the highest incidence rate of malignancy in women worldwide. It is a major clinical challenge is the frequent relapses after conventional therapies. Okay. Relapses and in breast carcinoma comes from the cancer stem cell. This is the new theory behind relapses and metastasis. As we see that cancer stem cells, those cells are generated when breast cancer cell undergo some transition from epithelial to mesenchymal, and then again to epithelial cells. This will result in aggressive, highly metastasizing, and invasive phenotype. When cancer stem cells are generated, this will lead to resistance to chemotherapeutics, as we will see when we proceed with this talk. As Prof. Muhtasim said that metastasis in breast is mainly residing on 4 molecular subtypes. These 4 molecular subtypes can be diagnosed with immuno or for hormonal receptors. It's the main cornerstone in diagnosing metastatic breast carcinoma. So they are divided in 4 molecular subtypes. Luminal A, this is the mildest one, seen mainly in white women, has a lower incidence of metastasis. In it, we see that ER, BR are positive, HER2 is negative, with Ki67 proliferative index is less than 20. So this is the most benign subtype for this molecular carcinoma. The luminal type, ER, BR positive, HER2 would be variable. positive negative with a proliferative index more than 20%. And we have HER2 overexpressed, ERBR negative, HER2 positive. This has high probability for developing metastatic disease. And the fourth type, which is the most aggressive type, is the basal type with triple negative breast carcinoma. This type possesses large percentage of cancer stem cells, and this leads to make it prone to develop metastases, difficult to treat, and is predominantly seen in Black women. So here we see that the subtypes with every type, so metastasizing to distant location, as we will see later on. As we know that breast cancer is the most common cancer in female patients. The incidence is rising worldwide despite early detection and intervention. Breast cancer death rate has declined by 44% in the recent years. Metastasis is seen predominantly in women more than 75 years of age. Most metastatic cases arise from secondary spread of previously treated early breast cancer with hereditary genetic mutation forming 10% of breast cancer, namely BRCA1 and BRCA2 mutation, along with B53, B10, check2, STK11. This form about 10% of the causes of breast cancer, along with lifestyle, environmental factor, as we know early menarche. This all we know about nullibility, lack of breastfeeding, late onset menopause, radiation, and other factors. The size, as Prof. Mu'tasim said, for metastasis can occur at any site of the body, but the most common size can be divided into regional and distant metastasis. Regional to ipsilateral breast, chest wall, and a lymph node, namely axillary, subpectoral, clavicular, infraclavicular, and internal mammary lymph nodes. While the distant sites frequently brain, bone, lung, and liver, along with distant lymph nodes, and less frequently to the thyroid, gallbladder, urinary bladder, gastrointestinal tract, gynecological organs, peritoneum, and retroperitoneal areas. So as Prof. Mu'tasim said, everywhere in the body can be a site for metastatic breast carcinoma. Okay, the pattern of metastasis associated with the biomarker status, as we said before, of the tumor. The organ to which cancer cell can metastasize is non-random, with the process being known as organotropism. Transformed cells need to decide whether to go or grow or go, either to stay and proliferate or migrate to other side, and where to go. For sustained survival as proliferation when it decide to grow, or migrate when it decide to go. Organotropism is regulated by multiple factors, such as cancer stem cell, as we said before, and tumor matrix stiffness. Despite such distinct clinical manifestation, breast cancer of different subtypes display different metastatic tendencies. As for the molecular subtype A and B tend to develop bone and liver metastases, while HER2 positive and triple negative subtype refer metastases to visceral organs such as brain and lung. So this organotropism hypothesis is a fertile soil for more elaboration or for more investigation on other organ metastases. Over 90% of breast cancer related deaths are due to secondary tumor in distant organ. This emphasizes the severity of metastasis. So metastasis is the process where transformed cells are disseminated from the site of primary initiation to different locations of the body. Complicated cascade involving invasion into nearby either blood or lymphatic channels, intravasation, circulation, extravasation at site of metastasis, and colonization. Expression of certain molecular mediators at the primary site as well as the metastatic site determine the metastasis of malignant cells to a particular organ. For example, vascular endothelial growth factors secreted from the tumor, signaling microenvironment in areas of metastasis, while cytokines and chemokines secreted from site of metastasis attract more malignant cells to the site of secondary metastasis, while silencing these chemokines and cytokines will suppress metastasis. Interestingly, breast cancer metastasis to different tissue is also dependent upon molecular subtypes, as we said before. Here we see transforming growth factor beta, one of the major tumor activator, metastasis activator, okay, leading to breast cancer metastasis, one of the most important metastasis activator. Here we see the cytokines and chemokines. They are major role in proliferation, migration, and invasion. Okay. To summarize, the main steps involved in the metastatic cascades of cancer cells are cell division and growth within the primary tumor, then invasion of the primary tumor border, basement membrane, and the tissue surrounding the tumor by the cancer cells, intravasation of the circulatory system, the cell enters the bloodstream or lymphatic channels. The cell must survive the transit into the new environment until it ultimately arrested in the microvasculature of the secondary site. And after that, extravasation to distant sites, the cell then invade into the basement membrane of the targeted tissue, proliferation of the cancer cells as a metastatic site, formation of micrometastases inside the secondary site, and progressive colonization, forming a life-threatening metastasis. This is the story of the metastasis. This is the journey that Prof. Mu'tasim said along the Nile from Tana lakes till the White Sea. The potentials of tumor cells to metastasize depends on its microenvironment, interaction with local factor promoting tumor cell growth, survival, angiogenesis, invasion, and metastasis. This is explained by the seed and soil hypothesis. So the tumor cells are the seed. When finding it is perfect soil, it grows. Here this table showing the metastatic activators, its role, and the potential therapeutic strategies that would be taught in this webinar. And here are the activators and the metastatic suppressor and their role. The diagnosis of metastatic breast carcinoma started with imaging modalities like bone scintigraphy, CT scan, PET scan, MRI, and hybrid imaging, followed by fine needle aspiration and core needle biopsy for metastatic site to evaluate cytohistological morphology, immunohistochemical marker, and obtain material for ancillary techniques. Okay. Also, we need to check if the serum of the patient cancer antigen 15-3 and 27-29, which will be elevated in 70% of metastatic breast cancer patients. We have also alkaline phosphatase elevated in bone involvement, liver function test in cases of liver mets, and so on. I think I must not go into radiological description after Professor Muhtasim talk, but to say it briefly, we have several imaging modalities, MRI, CT, and PET, every 2 to 4 months to determine tumor burden and treatment response. Finding are based on site of metastasis, usually found as numerous nodules, but can be solitary masses. MRI, in cases of liver, would be hyperintense lesion. In cases of brain, lesions would be seen predominantly in the gray-white matter junction and watershed areas. CT scan would show bone lucency, sclerosis, well-defined radio densities. The liver would be irregular hypodense lesion, and in the lung would show lymphangitis, lymphangitic carcinomatosis, pleural effusion, and so on. So here we see a case for mets showing hypodense, sclerotic and radiolucent areas. In the liver mets, there is a focus with hypodense area. Okay. Thanks for the lectures I attended. I come to know very ABCs about radiology. And here in the brain, we see also, this, I think this is the area of metastasis in the brain. Okay. The case of subcutaneous metastasis from post-mastectomy cases, there is area of the skin nodules, subcutaneous nodules, diagnosed by PET scan, and when taking biopsy, core needle biopsies, there is foci of dermal invasions. Here also, there is gastric mass, subcutaneous gastric mass, sorry, submucosal gastric mass. Under the microscope, the we can see that here's sentinel lymph nodes. As Prof. Muhtasim said, it is one of the challenging area, starting from the grossing at our site. When sentinel lymph node brought to the pathology department for diagnosis, from the very first handling of it, it is challenging. So it needs careful dissection, careful sample taking to ascertain the metastatic foci. Okay. The other are a little bit clear: liver mets, brain mets. We also need to do positive stains, okay, like trichorhinopharyngeal syndrome. When stained, this would be highly sensitive, 95 to 100% in identifying triple negative breast carcinoma, metastatic lobular carcinoma, and metablastic breast carcinoma. Also, we have GATA3, it's more than 90% positive in ER positive carcinomas. We have also hemoglobin, GCDFB15, SOX10, S100. Those are positive to varying degrees. Also, we have to do predictive biomarkers, ERBR HER2 biomarker at metastatic site from primary breast carcinoma, and should be performed at every new metastatic site. Okay. Also, we need to do the BDL1 positive. Would be positive in triple negative breast carcinoma, predictive for treatment with chemotherapy and with pembrolizumab. This would be more pronounced by the oncologist. Perfect pronounced. The molecular testing for predictive biomarkers are the germline BRCA1 and BRCA2 must be performed on all new metastatic patients. They are predictive for PARP inhibitor plus platinum-based chemotherapy. Also, we need to do BIK3CA, B10, and ESR1 mutation. They are predictive for targeted therapies or certain hormone therapies. And BIK3CA, this marker is used as second-line option in ER positive, HER2 negative breast cancer. And also we need to measure the tumor mutated burden. This must often be in triple negative and metastatic tumors, mainly in metastatic lobular carcinoma more than ductal carcinoma. They are predictive for response to treatment. Also, molecular testing on circulating DNA and serum approved to detect certain biomarkers. And also, we need to do the site hybridization for HER2 amplification and in equivocal state where score is +2. As 25% of cases with score +2 have HER2 amplification. Briefly about the prognostic factors in metastatic disease. Metastatic breast disease, as we know, has an overall poor prognosis. With the favorable prognostic factors include molecular subtype of luminal A tumors, or when the hormone receptors are positive, and if the metastasis is a bone-only metastasis has favorable prognosis. The unfavorable prognosis, the presence of number of metastatic axillary lymph node is the single most important prognostic factor in metastatic breast carcinoma. Primary tumor characteristic also, are prognostic factors, as some subtypes are more aggressive in breast with epidermal growth factor receptor mutation must be detected when found is of unfavorable prognosis. Also, the site and number of metastases would affect the prognosis. The disadvantage in social determinant of health, hazardous environments like alcohol, less breastfeeding, low social class, age more than 50 years of age. Black women have 38% higher mortality compared to white women. Briefly about treatment of metastatic breast cancer. Treatment is based on disease stage, number and site of metastasis, biological characteristic of the tumor, age, and overall health of the patient. Can be divided into systemic therapy, like hormone therapy, chemotherapy, immune therapy, targeted drug therapy, either palliative treatment or surgical resection, as would be decided by my colleague. Complete recovery is very rare with distant metastasis. Local treatment, lumpectomy, mastectomy, thermal ablation, and so on. Also, we have systemic therapy in cases of hormone receptor, HER2 positive, or in cases of hormone positive treatment or triple negative. All this will affect the modality of treatment, as would be more elaborated by my colleague. Thank you very much.
Thank you very much, Dr. Jihan, for this nice and inspiring presentation. We are very delighted to hear about pathological aspects of breast cancers. And it was very nice why you are telling you have a great presentation. Thank you very much for that.
Thank you.
I want
Thank you, Jihan. Thank you, Jihan, for your informative and thoughtful lecture and your elaboration on the pathology of metastatic breast cancer. Thank you again.
Thank you very much.
Thank you, Jihan. I also learned new things. Thank you.
Thank you
Thank you
very
so
much. Thank you.
Okay, let me share my screen. You see it here, this minute. Are you able to see the screen?
Yes.
Okay, so now it is our next presenter and speaker. Thank you very much, Dr. Jihan again. Now we are moving to our next speaker, Dr. Hussein Ali. He is a breast and oncoplastic surgeon, MBBS, University of Jazeera, MD General Surgery, SMSB, GCIE, FRCS, General Surgery, Fellow of European Board of Surgery, Senior Breast Oncoplastic Fellow at Royal Cornwall Hospital, UK. Dr. Hussein is an experienced oncoplastic breast surgeon. His work bridges high-quality surgical oncology with reconstructive expertise, ensuring the best outcomes for women with breast cancer. Thank you, Dr. Hussein. The mic is yours. You can share your screen.
Thank you for your kind words. Assalamu alaikum. I'll share. Can you see my screen?
Yes.
Okay, so the audience might notice there is some interactions and intersections between the different talks because we are all speaking about the same topic. So I will try just to concentrate mainly on the surgical aspect of the treatment. And I do believe that the lion's share is between radiology, oncology, and pathology. And the surgical role is very limited. Okay, so simply to define the MBC, metastatic breast cancer, we can say it is the advanced, secondary, or if you use the NCCN, it is a stage 4, or simply the TNM, it is M1, and at the simplest definition, any cancer beyond the local regional areas, breast and axilla. So, as we have seen in the previous lecture about the theory and how it happens, but I would like to speak about the polyclonal tumors, which is likely to represent why most of the cases are HER2 negative, ER positive, and although they respond, but there is reported cases of recurrence and distant metastasis 20 or 30 years down the line.
Sorry, Dr. Hussein, would you please share in full screen?
Full screen. Is it better?
Yes.
Okay. So, synchronous or de novo, that means the patient presented with the primary and at the same time during the workup, you find the secondary breast cancer. So this is a de novo or the synchronous or the primary from the beginning, and it represents roughly, depending on the region, 19% in the USA, 5 to 6% in Europe. And over the course of the disease, whether it is a de novo, synchronous, or metachronous, up to 50% of the breast cases develop some secondaries at some point. Estrogen receptor positive and HER2 negative nearly represent 2/3 of the cases. Although, as we have seen previously, during the pathology, it is luminal A, luminal B, and they are usually low grade, looking absolutely innocent. But in the end, it's statistically, most of the secondaries are coming from these early luminal cancers. So looking to this busy slide, here at the bottom, can you see my cursor? At the bottom, the less developed countries, yes. I don't like this expression, but this is the WHO classification we have to cope with. So Eastern Africa, looking here, we can see that the secondary breast cancer or metastatic breast cancer in terms of incidence can be up to nearly 30 something, and the mortality out of it, nearly half of them. So we, during the course of the disease, nearly 36% will develop secondaries, and half of them, unfortunately, will succumb to this bad disease. So, by definition, MBC is incurable. And regardless of what type of intervention, whether it is local or systemic, it is, in the end, most of them, or entirely all of them, will die of this disease. So generally speaking, for triple negative, we expect the survival to be around 2 years and more with the luminal and HER2 enriched. So if at the end, all of them will die, then why do we care? there is weak evidence that we can extend survival by intervening and treating patients at this stage. But most importantly, we are looking for palliation and support, because we can't say this is terminal, go home and die. So we need to support and palliate, mainly because the aim is not to cure the disease, although there is some cases can show some hope. So de novo or distant recurrence, as I expressed earlier during the presentation, or the patient is already treated and they have a period of disease-free survival, and then they develop the distant recurrence or metastasis. They can be oligometastasis, which is defined less than 5 spots, or polymetastatic and extensive. It can be bone disease only, and we can see that 40% of the metastasis will be bone disease only, and by far it is the common site for metastasis. Visceral metastasis, including lung and pleural effusion, liver metastasis, jaundice, ascites, brain, and the dreadful leptomeningeal metastasis. So, how we diagnose? So technically, if we have a patient with a primary cancer that is proven to be histologically a breast cancer, and during the course of staging, we have a typical imaging from the rats that it is typical for metastasis, we don't need to go and hunt for a biopsy from the metastasis. So a patient with a stage 4, T4 disease, you take a core biopsy, it is ER positive, HER2 negative, lymph nodes positive, and there is typical lung metastasis or liver metastasis. We don't need to biopsy them. As the phenotypical discordance between the primary and secondary in the synchronous and de novo cancer is between 1% and 2%. So extremely unlikely to have a flavor and breed in the breast that is discordant to a de novo metastasis. However, the distant recurrence or the metastasis that happens after a span of time, there is up to 40% of phenotypical discordance. That is why, especially if the treatment is more than 1 to 2 years ago, you need ideally a tissue diagnosis from the metastasis to rule out the discordance. As we can see here, the ER discordance can be up to 19%. That means a patient with ER positive cancer treated 5 years ago, now presented with bone metastasis, and if you have image-guided metastasis biopsy, then you can find it now ER positive. That doesn't mean it is a different cancer. It is the same cancer, comes back, but with phenotypical discordance. That's why in the metachronous condition, we need biopsy. So we can see.
May you explain it again? This point of discordance.
Okay, so you have a patient presented with breast cancer. You take a biopsy from the breast. It says grade 3 invasive ductal carcinoma, estrogen receptor positive, progesterone positive, HER2 negative. And during the assessment, you do a CT scan, you send it to Rabab, and she says, I'm sorry, this is a typical lung or liver metastasis. I don't need to biopsy as far as it is typical in the imaging, because I have a biopsy from the breast telling me what type and what breed and what flavor of cancer in the breast.
Yeah.
But the same patient treated with mastectomy, radiotherapy or chemotherapy or anything, and she's free of the disease for 10 years. And then presented in the emergency with a hip pain, and it is a pathological fracture, and it is lytic lesion, typically for a secondary from a breast cancer. There is 10 years gap between the primary cancer and the metastasis.
Yeah.
At this point, it is better if you can to have a tissue diagnosis, because sometimes the cancer that started as ER positive might come back as ER negative. And that has
Okay.
implication of how to treat. This is called the phenotypical discordance between the primary and the secondary, especially in the metachronous situation.
Because of time lag.
It is mainly due to the polyclonal nature of the cancer, because when we say this cancer is estrogen positive, we don't mean all the cancer cells are estrogen positive. So the pathologist can correct me. So if you got more than 10% of them is 10 positive for the ER, you call the whole cancer as ER positive, whereas actually not entirely it is estrogen positive. There is some clones that are actually estrogen negative, but you treat by the dominance.
But I mean, the chance it will to happen that or to occur is a time lag. Because
Like,
immediately,
yes.
This is what I mean.
Yes, absolutely. That's why we said if it is at the same time, it is just 1 to 2%. But if it is more than 2 years, it is likely to be, as you can see, 19% in ER, 31% in PR, 10% in HER2, and even in the ER.
Or the metastatic cell are the ones that are ER negative?
Likely. Yeah, because most of the times you get a breakthrough that the patient is already on tamoxifen, already on aromatase inhibitor, and they develop metastasis. So if that cancer is ER positive, why it should recur during the treatment or after the treatment? That's why you need to put this in mind. It is not 100%, but it is nearly 40% will come back as discordant. That's why tissue diagnosis is paramount if you have a long span of time between the primary and the metastasis. And also you look, as Jihan said, for the PD-L1, for pembrolizumab, as proven by the Keynote 522, and also the BRCA1 and the PARP inhibitors and Olympia trial. I will leave that to the oncologist to explain it more. So why we are interested in metachronous phenotypical discordance? Because it is associated with poor prognosis, especially ER positivity loss. If the primary cancer is ER positive and down the road recurred as negative, that is a sign of poor prognosis. And also it has implication on the treatment. If the patient is already on endocrine treatment, now you might need to discuss it with your oncologist to consider chemotherapy, for example. So if it is a metachronous cancer and you have a local regional recurrence at the same time of a distant recurrence, it is easy. You can just take a punch biopsy to reach a diagnosis. But if the secondaries are in the liver, in the lung, in bones, then you need to speak to Professor Mu'tasim or Rabab to help you out. And sometimes you can do a cytology from a pleural effusion or acetic tap. You need some sort of confirmation. However, the cytology, most of the time, is not enough to diagnose receptors. You can just confirm the disease. That's why the surgical biopsy or a tissue biopsy is very important, so the pathologist can run the test and tell you about all these receptors. So if the distant recurrence are metachronous with no locoregional findings and the biopsy is not possible, so you have a patient treated for a primary cancer 10 years ago, now presented with just distant recurrence. There is no locoregional tissues to take. You don't have the facility to diagnose the synchronous breast cancer. what should I do? So generally speaking, if you don't have access to do a tissue biopsy in the metachromas status and your radiologist is happy, that is typical for secondary breast cancer, you can treat it simply as the primary. And for any reason, especially like in Sudan, if you don't have access to the primary diagnosis, you can assume simply it is ER positive, because 2/3 of the cancers will be AR positive, HER2 negative. And also, if you are trying to palliate, it's better to start with endocrine treatment in comparison to be tough with chemotherapy for somebody who's already not aiming to cure. Is that clear? So some people, they will say, if you know the primary and it is less than 2 years, you can carry on treat it as the primary. If it is more than 2 years and you don't have access to do a biopsy, it is better to assume the commonest discordance, which is ER loss. So it was ER positive, required more than 2 years.
Sorry, you can continue.
Okay, but if it is more than 2 years and you can't do the biopsy and the patient is fit, it's better to start with chemotherapy, assuming that commonly up to 75%, if it is a chance to have a discordance, it will be loss of positivity and the patient might get better survival from trying chemotherapy. Although this is just a weak evidence, there is no strong evidence to support this. There is no clear guidelines from any reputable institute to tell us what to do in this case. So it is up to the patient, to the fitness of the patient, to the wider MDT to decide how to treat in such critical position. So the discussion will be, as I said, with the patient, next of kin, assessing the burden of the cancer, whether it is bone-only disease, oligometastasis, or solitary metastasis, any organ dysfunction, and the fitter the patient, the better you can give aggressive treatment aiming for a better survival. And also, as we can see from the previous lecture, we can't afford doing anything, especially in a situation like in Sudan, and we need to be careful and to try to choose wisely. So there are some emergencies in the metastatic setting, like hypercalcemia from extensive bone metastasis, and that needs intensive care. And most of the time in the acute care setting, they will be in the ICU. Coda-equine syndrome, and you need the help from the spinal surgeon or the neurosurgeons, and fulminant hepatic failure with extensive hepatic metastasis and replacement, and jaundice, convulsions, especially with extensive brain metastasis. So these are very sad and very terminal, but they need addressing. So for hypercalcemia, admission, calcimimetics, and aggressive rehydration can solve the job. So generally speaking, this is like a schema about what to do in terms of ER positive and ER negative, whether it is visceral or bone-only metastasis, whether it is HER2 or HER2 positive or negative. And I don't want to elaborate more. I will leave that to the oncologist. But think of monotherapy versus combination according to the fitness, and immunotherapy, and considering the CDK4 and CDK4 and 6 inhibitors, like the ribociclib and abemaciclib. Now, the role of surgery is very limited, as I have said earlier, and mainly for palliation or complications. Because if we are not aiming for cure, there is merely nothing to do from surgical perspective. So whenever we diagnose a patient with metastatic breast cancer, we send them to a different MDT, and it is likely led by the oncologist to try to do whatever is possible for them to die in peace. It is very cruel, but that is the reality. However, pathological fracture, the surgeon can have a role in doing open reduction and internal fixation like pathological fractures, vertebral fixations to avoid caudal guano syndrome and to avoid cord compressions and to relieve pain. And there are some fancy techniques like a cyber knife or a gamma knife and different stereotactic radiosurgery and ablations mentioned previously by my colleagues. So, is there any role for surgery for the primary tumor? So most of these studies are retrospective and there is a lot of bias on them. And the TATA trial and the E2108 are the most famous, comparing between surgery for the primary tumor versus systemic treatment. So simply, a theory will say, if you take out the primary tumor, you stop the source for metastasis. You stop the seed source. You can get rid of the pacemaker that sheds these cancer cells. And also, it will help the immune system to fight, and it will help the patient to tolerate any cancer treatment that you use. So, although there are some studies that support the surgery for primary tumor, it is not the gold standard, and we don't do it routinely, and we do it only in selective cases. So if a patient diagnosed with metastasis, there is no role for just removing the primary breast cancer unless there is a clear indication like local complications, bleeding, infection, fungation, or psychologically the patient cannot cope seeing the cancer in their body. And we need to remember, most of these patients that those come with metastasis are not even fit for haircut. Let it be surgery. That's why we need to be wise and to assess their fragility and how they can tolerate any intervention. And if it is needed, we can have an anesthetic assessment and discuss whether it is safe to carry on with general anesthesia. Or recently, we're starting to do all the palliative interventions for breast surgery, specifically here in the UK, and the regional blocks and sedation to avoid the complications from the general anesthesia. So this is an example, fixation for fracture in the head of femur, and fixation for the spinal cord, secondaries, and very, very limited role for liver metastasis in terms of metastatectomy. But in the colorectal cancer, it is very well established practice that to excise the metastasis from the liver, and it is proven to be of a survival and control benefits. There is no such a thing in the breast. We don't do liver metastectomy in breast patients. Lungs are the same, especially, but sometimes we can think of chest drains, and if there is bleeding, bronchoscopy, or embolization, chest drains and pleurodesis to obliterate the pleural cavity and to alleviate the pleural effusion. And all this shared embolization, as mentioned earlier by the interventional radiology by Prof. Mutasem. So, for premenopausal patients with metastasis, you need to discuss it with the gynecologist to consider oophorectomy, and that is for an obvious reason, to control the estrogen production from the ovary, or you can do it medically by using zoledronate. So these are the cases sometimes we intervene because obviously the patient cannot cope with this local cancer, and we can offer them palliative mastectomies, which was 10 years or 20 years ago, it was called the toilet mastectomy, but it's now called palliative mastectomy. Sometimes it's very difficult to close the defect because the cancer is very aggressive, very fungating, and you need to collaborate with your plastic surgeon colleagues to see if there is any way for a keystone flap or Limburg flap or an abdominal advancement flap to close the defect, and sometimes even they can consider a skin graft. You can see how horrible it is. Even if the patient is about to die, it is fair and better for them to get rid of this, to live for a few months in peace and not to suffer seeing this every day. That's why, although we don't do it as a standard, we are very careful. If the patient is fit, we don't let them live with such a horrible cancer. So if there is infection you can't control, if there is bleeding, and as I said, you consider plastic surgery like flaps and graft. So does removing the primary cancer improve survival? We don't know. The evidence is very weak. However, in malignant melanoma, renal cell carcinoma, colorectal cancer, metastastectomy has proven to be beneficial in terms of survival and outcome. In metastatic breast cancer, there is evidence to support bone-only disease, especially if you have a solitary deposit in the skeleton, especially if the patient is ER positive and you discover it and you do it in the first year. And also there is benefit in HER2 positive disease because you can use the dual anti-HER2. It reduces the burden, as I have said. It reverses the the tumor-induced immunosuppression, and also the psychological effect, as we all seen in that horrible picture. So oligometastasis, that means if the deposits in the whole body are less than 5, 5-year survival can be as high as nearly 60%. Whereas in polymetastatic and visceral metastasis, lung and liver and brain, the 5-year survival can be as low as 3%. That's why if there is any place to offer surgery for the primary cancer, it will be for oligometastasis and younger, fitter patient with bone disease only. However, if you have a patient, as you can see from the series presented by Prof. Mu'tasim, a patient with multiple liver metastases, you send them across to your oncologist and they give them a nice regimen of treatment, and you've seen them in 20 months and they're absolutely banging on, absolutely fine, good responders, long survivors. However, they still think that the cancer is in their breast, although it will respond, but it will stay in their mind. So we can offer primary cancer like a mastectomy or a lumpectomy or a clipectomy or anything, just for psychological reasons, especially if they are long survivors and good responders. And there is also evidence to suggest that radiotherapy after removal of the primary has a better outcome in terms of local regional control and even overall survival. But the evidence is not strong, and it is mainly relating to the HER2 negative, ER positive cohort of patients. So some has actually gone so far, they offer reconstruction. We have 2 cases in our unit. We offer them reconstruction after responding very well for treatment for bony metastasis, and one of them for a lung metastasis responded very well for chemotherapy, and we offered her mastectomy and reconstruction. And there is a case that's even after a good response, she started a family, conceived and gave birth. But these are not the standards. These are the exceptions. And you have to be very careful not to give any false hope, as MBC is incurable. So take-home messages from today: luminal A, luminal B, and HER2 negative, bone disease only, solitary or oligometastasis. Young and fit cases may benefit from primary removal of the cancer. It is not the standard, as I have said, but it is an MDT, and specifically metastatic MDT discussion. Palliative intervention should be discussed with the patient, their next of kin, depending on their life expectancy, and to consider also non-surgical options. So for a fungating tumor, sometimes local short course of local radiotherapy, especially with the new trial, the Japanese trial of Cortac, where they inject hydrogen peroxide in the tumor and offer a short course of radiotherapy with a good response. We call it the bleach trial or Trump trial, because Trump asked his people to drink bleach to kill corona. Palliative intervention should be carefully planned, and the approach in the future might change if there is any strong evidence to support the removal of the primary tumor. Last but not least, to our beloved country, we always say, this too shall pass. Thank you.
Thank you very much. Thank you very much, Mr. Hussein, for an excellent, interesting, inspiring, and evidence-based presentation on the role of surgery in metastatic breast cancer disease. Thank you again.
Thank you so much. Any questions? Comments?
I have a question, but I think better after oncology session.
So if I may, I during the presentation, I looked to the audience and I picked a name. I would like to thank him very much, Mr. Osama Mustafa. He's my teacher, he's my mentor, and he was the one who convinced me to switch from obs and gynae to surgery. He's
Also would like to thank him.
he is a senior consultant plastic surgeon in King Faisal in Jeddah. Thank you so much, Mr. Osama. I met him back in 2003, and at that time I've already bought my stuff to sit for the first part of obs and gynae, and he did his magic and convinced me to switch to surgery. Thank you, Mr. Osama, and I'm happy to see you in the audience.
In Germany, the breast is...
Yes.
So you are still in the field.
Yes, yeah, it is part of the gynae in Germany.
Yeah, it's a gynae and it's a topic, yes.
Yeah.
Thank you for your lecture. It was very informative. Thank you very much.
Thank you.
So now I will again thank you very much, Dr. Hussein, Mr. Hussein, for this excellent overview, interesting and inspiring presentation on the role of surgery in metastatic breast cancer. So moving next, we are moving to Dr. Rehab Abdullah Usman, consultant medical oncologist. She will guide us through the current therapeutic strategies in metastatic breast cancer. She is MBBS Khartoum University, MD Clinical Oncology, Sudan Medical Specialization Board. Dr. Rehab is a member of European Society of Medical Oncology, member of American Society of Clinical Oncology. Dr. Rehab is a clinical oncologist with a strong focus on evidence-based systemic therapy. She's committed to improving oncology care and advancing multidisciplinary cancer management in Sudan. Here you are. The mic is yours, Dr. Rehab.
Thank you so much, Ala, for this presentation. And I want you to share my slide because I couldn't share it with you from my side.
Yes.
Thank you so much.
Yes, you can start.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على المبعوث رحمة للعالمين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you so much, Dr. Rabab and the team for this extraordinary effort. Thank you so much. So always I'm saying that oncology is the last destination for the patient journey. And the patient, when it comes to oncologist, they usually unwilling to do more investigation. So we do a great effort to minimize our investigation in the poor financially very poor financial status of the patient. So for metastatic breast cancer, it needs to sit with the patient, and most of the patients, they know the stage of their patient when they come to the clinic. We have to stay a lot for them to make a counseling and to give them idea about the options of treatment. And as you see, you know, the presentation of our patient in our country as a developing country is always common, either a locally advanced disease or metastatic disease. We rarely see the patient with early stage of the disease. And unfortunately, we are facing a lot of patients either with locally advanced disease and with this metastatic disease. Next. So 40 to 50% of early stage, unfortunately, later develop metastatic disease. And according to breast biology, hormone receptor positive disease are known to have a late recurrence and good prognosis. So in general, metastatic disease are not curable, and the intent of treatment is palliative treatment. So putting in mind that metastatic disease is considered the cause of morbidity and mortality. So as this situation, our goal of therapy is to control the symptoms of the patient, to prolong survival, and at the same time to minimize the toxicity from the therapy. All this to preserve a good quality of life. Next. So what makes a patient with metastatic disease? Everyone is different from the other patient. I think the performance status, the comorbidity, and the host factors, genetic factors, and the prior treatment that the patient received, the extent of therapy, and the response to this therapy. Also, the disease-free interval, either it is long or short. And site and volume of disease also it matters. And the biology of the breast, ER, PR, negative or positive. And of course, the HER2 status, either positive, negative, and nowadays also either if it is a HER2 low or ultra low. And my colleague, Dr. Hussein, covered the biopsy taken from the metastatic site in details. So treatment for metastatic breast cancer influenced by many factors, by how long the disease-free interval, as I mentioned, by HER positivity, breast biology, HER2 positive, ER/PR negative or positive, rapid progressive visceral disease, and the refractory to endocrine therapy. Also disease refractory to anti-HER2 therapy and immunotherapy targeted therapy. So how to treat and upon what we put a plan for treating metastatic breast cancer. We have to individualize treatment for every patient according to the performance status of the patient, the comorbidities, as I mentioned. We have to treat the symptoms first and identify the emergencies. Patient may present with port compression, superior vena cava obstruction, may present with hypercalcemia, also an acute kidney injury. So we have to consider or put in mind prior therapies and duration of response and comorbidities, and considering goals and preference. Next. And it needs a multidisciplinary team to be involved: palliative care, supportive care, pain specialists, medical radiation, surgical oncologist, pharmacist, physical therapy, social work, and hospice team nurses. Next. So the therapy that directed to breast biology in hormone receptor positive. Nowadays, we cannot treat breast cancer with only endocrine therapy. We have to use in combination CDK4/6 inhibitors for treating patients in early and metastatic situations. Next. So for the CDK4/6 inhibitor, they have constant progression-free survival improvement, and it showed endocrine sensitivity, and it is nowadays partner. We have to consider the menopausal status and the visceral involvement. We have famous trials studying the CDK4/6 inhibitor in combination with hormonal therapy, either aromatase inhibitor or selective estrogen receptor down regulators. For example, BALLUMA-2 trial, which is studying letrozole with palbociclib, Mona Lisa 2, which is studying ribociclib with letrozole, and Mona Lisa 7 for tamoxifen, gozerline, ribociclib, and aromatase inhibitor. Monarch 3, non-steroidal aromatase inhibitor plus or minus abemaciclib. Mona Lisa 3, studying fulvestrant with ribociclib. Next. CDK4/6 inhibitor had predictable, tolerable, and manageable side effects, all requiring CBC monitoring and also liver function test monitoring, especially for ribociclib. Ribociclib also needs to do ECG regularly. Abemaciclib had major side effect is diarrhea, which is manageable by anti-diarrheal agent, and also has reported cases of VTE, unfortunately, with abemaciclib, so patients need to be followed carefully. Next. So in conclusion, sequential endocrine therapy is the cornerstone of the treatment, and chemotherapy as a first line is limited to very few cases in hormone receptor positive, and taking into consideration menopausal status, previous therapies, disease-free interval, and symptoms. Aromatase inhibitor, balbo, ribociclib, abemaciclib in the front line setting, and there is a limited use for CDK4/6 inhibitor beyond progression. Also, fulvestrant as a second line with balbo, ribo, abemaciclib patient previously treated with endocrine therapy, or second line that did not receive CDK4/6 inhibitor. Also, fulvestrant with alpelisib in patient with PIK3CA mutation, previously treated with IAI and has a mutation in PIK3CA mutation pathway. Fulvestrant capivasertib in PIK3CA in patient previously treated with aromatase inhibitor with alteration in PIK3CA ACT and BTN pathway. Also, mTOR inhibitors with steroidal aromatase inhibitor, elacestrant in ESR1 mutant patient. And nowadays in ASCO 2025, we have a SERENA trial, which studied introduction of camizestrant in early recurrence that is detected by circulating DNA before any progression evident in radiological studies. This is a practice-changing, I think, this trial, SERENA trial. Also, those who carry BRCA mutations, they can benefit from PARP inhibitors. Next, Anna. So as a conclusion from CDK4/6 inhibitor trials, we can conclude that. Next. High response rate, 50 to 60%, 50% BFS improvement in overall survival, as detected in Mona Lisa 3, 7, and Monarch 2, and others. Updated survival analysis shows consistent result. The set new standard of care for hormone receptor positive HER2 negative in a first and second line setting. Different side effects profile needs to be recognized early and managed accordingly, and close monitoring and follow-up, as I said, for CBC, LFT, and ECG for ribociclib. Next. For therapies beyond the CDK4/6 inhibitor, second and third line, according to Destiny Breast 04 study, we have trastuzumab deruxtecan, sacituzumab govitecan, also studied in TROPICS-2 trial, an oral selective estrogen receptor diol regulator, elicistrans, in Emerald trial, data from AKTI inhibitors, Capitello, and PARP inhibitors. Next, please. Trastuzumab deruxtecan approved by FDA for HER2 low metastatic breast cancer in patients with no more than 2 lines of chemotherapy. Sacituzumab govitecan improved OS compared to standard chemotherapy in endocrine refractory metastatic breast cancer who have received 2 to 4 lines of chemotherapy. Oral selective estrogen receptor diol regulator, elicistrans, improved BFS in metastatic breast cancer who have received 2 lines of therapy, endocrine and chemotherapy, and prior CDK4/6 inhibitors. ACT inhibitors, capivasertib, have a promising activity in who have received at least 1 line of therapy, endocrine and chemotherapy, and prior CDK4/6 inhibitors. Next. So let us come to another breast biology, HER2 amplified breast cancer, which represents 15 to 20% invasive breast cancer. It has a poor prognosis and tumor more likely to be high grade and to have lymph node involvement. Next, Anna. HER2 targeted drugs studied in Cleopatra trial. It's phase 3 study of trastuzumab, bertuzumab, combination with docetaxel. And this is the dosing of the treatment. As we know, anti-HER2 therapy double blockade, bertuzumab, trastuzumab, has a loading dose and then maintenance dose. In combination with docetaxel, 75 milligram per meter square, escalating to 100 milligram per meter square if well tolerated. And the primary endpoint for this trial, it was assessed, it was BFS. A first line for this breast phenotype is docetaxel, bertuzumab, trastuzumab. Remember to stop chemotherapy 6 to 8 cycles to continue anti-HER2 therapy when we usually use for 1 year, or we can stop it if intolerable toxicity like cardiac toxicity mainly. Also, we have tocatinib, tyrosine kinase inhibitor drug, which is approved 2020 in combination with trastuzumab capecitabine for treatment of advanced unresectable or metastatic HER2 positive breast cancer, including patients with brain metastasis who have received more than equal or more than 1 previous HER2 targeted therapy in the metastatic setting. It is oral treatment, 300 milligram taken oral daily, twice daily. Dose can be reduced to 100 milligram per meter square oral twice daily for patients with severe hepatic impairment. It causes severe diarrhea, so we have to use anti-diarrheal agent, and also it can cause hepatotoxicity. We have to monitor the ALT, AST, and bilirubin prior to start tocatinib every 3 weeks during treatment and as clinically indicated. Management of adverse effects may require temporal interruption, dose reduction, or discontinuation. Approval based on efficacy data from randomized HER2 CLIMB trial. This is a trial which approved accordingly. Next. Second line for anti-HER2, we can use trastuzumab deruxtecan, and we have to put on mind the lung toxicity, ILD, interstitial lung disease, to adjust the dose or according to the grade of toxicity for temporal for permanent withdrawal of the drug. ILD with trastuzumab deruxtecan. We can use third line TDM1 also for as anti-HER2 therapy. And the dose adjustment for TDM1, it depends upon the platelet because it causes thrombocytopenia and LFT monitoring. Next. So for HER2 positive patient, we need to know the HER2 status, know the ASCO CAP guidelines, likely clear if positive. New therapies have changed the natural history of this disease. New agents are part of standard treatment. First line, we use trastuzumab, pertuzumab, docetaxel. Second line, trastuzumab, DXD. Third line, TDM1. HER2 positive, hormone receptor positive, it is okay to use both endocrine therapy and anti-HER2 therapy at the same time. So for triple-negative breast cancer type, as you know, this is a very aggressive type of disease, as my colleague mentioned, characterized by early recurrence within 2 years, most common in African women, and lacking the directed therapy or targeted therapy, but immunotherapy is now playing a big role in triple-negative breast cancer in early setting and metastatic disease. Next. So evidence of immunotherapy in advanced triple-negative breast cancer, first-line setting, atezolizumab as immunotherapy studied, but it was early withdrawn by in Invasion, according to Invasion 130 trial. And now we are treating triple-negative metastatic disease with pembrolizumab in combination with therapy, chemotherapy, either paclitaxel or carboplatin, according to Keynote 355, discussed in ASCO 2020. Also, sacituzumab govitecan can be used in triple-negative and also in hormone receptor positive. In both, according to ASCENT trial, randomized phase 3 study trial of sacituzumab govitecan versus treatment of physician choice in patient with previously treated metastatic triple-negative breast cancer but after more than 2 lines of therapy. Also used in hormone receptor positive, this drug studied in trial which is called Tropics 2 trial. Next, please. So the question, is there a standard first-line agent? Anthracycline taxane often considered first-line agent triple-negative, but now used increasingly in neoadjuvant setting. No evidence that precise sequence of therapies affect overall survival and quality of life, and response rate more influenced by the line of therapy. So taxane, paclitaxel, docetaxel, nab-paclitaxel, anthracycline, liposomal doxorubicin, capecitabine, eribulin, platinum, gem-carbo, gemcitabine, single agent, PARP inhibitors, all are new molecules, immunotherapy, sacituzumab, trastuzumab, deruxtecan. All these drugs are used in the triple-negative breast cancer according to the situation, to the prior therapies used, and importantly, the availability, especially for immunotherapy, for sacituzumab, for trastuzumab, DXD, and the investigation which require to be accordingly to be given this treatment. So immunotherapy metastatic breast cancer, pembrolizumab, chemotherapy in first line with nab-paclitaxel, gem-carbo in only PD-L1 positive, and we have to be cautious and careful with toxicities like interstitial lung disease, hypothyroidism, and also you have to be careful with the contraindication for this treatment. Next. Conclusion, chemotherapy single agent. We have to give single agent since our intent of treatment is not curative. As I said, it is a palliative treatment, so we usually use single agent. We do not prefer to use combination and to let patients suffer from more toxicities. So chemotherapy single agent is better unless we need a rapid response and patient with a good performance status, and have to take into account previous therapies and the disease-free interval, and no clear sequencing is established. So taxane, paclitaxel, nab-paclitaxel, anthracycline, liposomal doxorubicin, ixabibolone, plus or minus capecitabine, eribulin, platinum, gem-carbo, all these drugs are used in triple-negative metastatic breast cancer. So pembrolizumab only for PD-L1 CPS more than 10, also olaparib, PARP inhibitor, talazoparib in BRCA mutation, and we have to remember to test this for both hormone receptor positive and tribin negative. And we have to remember and to consider that giving satizumab govitecan should be after 2 or more systemic therapies. So it is not allowed to give the patient as a frontline therapy. It is not allowed to be given after first line therapy, at least two line of therapy preceding satizumab govitecan and not exceeding the 4 lines. Trastuzumab deruxtecan is widely now used for only HER2 +1, +2, low and ultra low HER2 status, and not only nowadays. Trastuzumab deruxtecan is widely used in other malignancies, cancer, lung, colorectal, and gastric cancer. Next. So metastatic breast cancer is incurable condition. Better therapies, better therapies or choice of therapy should be tailored according to the patient performance status and availability, as I said, for this patient, because our intent is palliative. We have to know the status of the biology of the breast, ER, PR, HER2 status, and with relapse, you have to take a biopsy because patient breast cancer tumors, they change their biologies. I'll just cover in details with my colleague, Dr. Dr. Jihan. So we have to treat according to subtype. We have to take a biopsy and treat according to subtype. I think we have to think about previous therapy toxicities. Have to put in considering menopausal status, and have to recognize emergencies as compression, fractures, hypercalcemia. And we have to use, of course, the bone agent for metastatic breast cancer, like monoclonal antibody denosumab, zoledronic acid. This bisphosphonate also can be used early breast cancer with those patients elderly with aromatase inhibitors. Also should be used denosumab, zoledronic acid. I think this is my last slide. Thank you so much.
Thank you, my dear Rehab, for an informative, amazing, and evidence-based talk on the role of clinical management of metastatic breast disease. Thank you again. Thank you again.
Thank you, Rababa. Thank you, my colleague speaker also. They cover most of my slide, actually. Dr. Hussein, Dr. Ajihan, Dr. Dilbag.
Thank you for all of you. All are excellent, excellent and amazing presentations.
When it comes to my presentation, I feel that like everything is covered. What I'm going to add?
No, because it is new. Most of these are new for us. So we didn't feel the repetition. You see? Yeah, it was good for us to understand more. No, you are not repeating. We understand more. More explanation, more understanding. We enjoy it. We enjoy it all time running very fast.
Thank you, Rababa. Thank you.
Thank you very much. Thank you very much. It was really good, but you reminded me of now it's become more intricate. Since I was at Stack Laboratories, I was always asking for an oncology course for histopathologists.
Oh, oncology.
An oncology course for histopathologists.
Yes, and even the oncologist, once again, Dr. Nadia, I recommend to have 3 months at least in the pathology department. Nowadays you cannot treat metastatic disease without
yes.
test, very difficult, very difficult.
Yes,
I think these collaborative lectures in all specialties is a good chance for all of us to understand other specialties.
Unfortunately, Rababa, Dr. Nadia, before this conflict in Sudan, we have made some sort of collaboration with Well Cornell Medicine in New York for the international cancers of breast cancer subtype, and they came to Khartoum Oncology Hospital. They test all the pathology department, the radiology department to see what is deficient and to check even for the reagent in the pathology department.
I do remember that. I do remember I was with you.
Yes, and we are just about to start this project. It was mainly studying the affinity, what is beyond triple negative. That is, it is more common in Africa, ladies. What is beyond? So we
And
are
in
about
Sudan,
to start.
yes.
Yes, we are about to start this project. Even the questionnaire is became ready. This was in January 2023, but unfortunately, all this has gone. And when I contacted them, they said that it is unstable situation in Sudan, so we cannot conduct. We hope in near future everything is going to be better to start this. But very sad, you know.
Yes,
We do not
definitely.
Just I
There
do
is so
remember
much to
that
study.
we were there together in the
Yes.
MDT in
Yes,
Khartoum.
indeed. And we are planning even to do online clinics with them. If you remember.
You have where the pathologists are trick involved
in this project?
Yes.
Yes, I see. I remember Dr. Nazir, he's now out of the country. We involve
Nazir Nazik al-Malaika.
Yes, Dr.
All
Nazir.
of them were involved. That's
yes,
lovely.
Yes. And even they request us to have a surgical department in the hospital. They said that we cannot start unless. So we went to Khartoum hospital. They met Dr. Aida and make some regulation to support the surgical department in Khartoum to be part of Khartoum
of this project.
Hospital.
Yeah. And I had mentioned in SOBA also to Professor Rashid that why not include when the surgeons are doing the registrarship in SOBA, why not include that they spend time in our department actually as such, but maybe for the time or a shift that they are in SOBA to follow up the specimens, to know exactly what happens to the specimens. Because you cannot ask a surgeon to come for 3 months, for example, to the department and stay there. But just to follow his specimen and see exactly what happens to the specimen that he removed. So that there is continuum.
دكتورة نادية.
Yes.
الجماعة عندنا هنا في الهيستوباثولوجي بيقولوا لك أنت يا تجي باختيارك أو حنجيبك غصبا عنك. بالنسبة للسيرجن. لأنه if you come by your own, you'll see how we process the specimen, and then you'll be oriented how to orient it, how to paint it, how to send it, how to fix it in formalin. Otherwise, if you commit a mistake, we'll call you and you will come, and we call it the walk of shame.
Yeah. Tamam, this is wonderful. لأنه we had I think he was Irish who came for sessions in SOBA مع ناس عبد الحميد. The two Omars, the surgeons in SOBA, and they were doing rectal cancer removal, and he was very specific in telling us pathologists that we should be involved. We were involved in the whole 2 days training, and exactly how to, because it's the continuation of your work as a surgeon. If we don't connect, I cannot give you the result on which you will treat your patient. So I remember he was most insistent that we receive the sheet from the Royal College طبعا guideline, how to resect the specimen, how the specimen should be handled in the lab, and that the surgeon puts this sheet with it, with the request. Otherwise, their training would go just, it wouldn't be useful. Of course, the link is very important, but this has been something when even radiology in Sudan, oncology in Sudan wasn't that diverse. I was always asking if oncologists can tell me about a course that pathologists can take, even an online course, because it's becoming very intricate. When you are talking rehab, I suddenly, with all those names like you were mentioning, at one point I got lost. It is really difficult because it's become a very intricate field. You have to know so much. The surgeons are going in the same way. You have all these trials going on. So it is very difficult. We are trying to keep up in our area. And we are general pathologists. Most of us are, until now, are general pathologists with an area of interest. That is our specific area of interest. but we are not dedicated to one area. So it's very difficult to keep up in our field, regardless of oncology and surgery and so on.
That is why I told her we couldn't recognize that there is
Yeah,
a lot of
it's
repetition.
no repetition. Believe me, it was no repetition for us.
No, for us it was no repetition. You are the one who recognize the repetition because you understand every single word. For us, we are trying to cope. We are trying to.
We were trying to cope, yes, to keep up.
What you are saying.
والله رباب دكتور نادية يعني
can I
I'm
say
afraid
something?
not to be able to practice
sure,
oncology
Prof.
at oncology.
Can I say something, يا جماعة? Can I say something? Yes. I'm following the whole discussion يعني. It's great. Okay. ما شاء الله كمان التواضع يعني. هذا الشيء يعني شيء عظيم. هذا اللي يطور الفرد ويطور المجموعة كلها. الإنسان كل واحد يتواضع أكثر من الثاني. لكن بالنسبة لل learning and training in pathology كان في زمان الارmed forces institute of pathology في أمريكا توقف لكن استمر armed forces institute of radiologic pathology. Okay. عندهم كان عندهم 3 weeks course الآن بقى 4 weeks course. It's compulsory for any radiology or pathology trainees in the United States to go to that course sometime during their 4-year training. وفي ميوزيوم من الاكس رايز ومن الباثولوجيز ومن الجارز ومن السلايدز. انا I missed to go there لانه when I became radiologist خلاص بقى ما عندنا funding to go for يعني 4 weeks away وفيز عالية هناك وتكون ساكن. ف داس يعني حتى أولادنا السعوديين بيمشوا training هناك للفيلوشيبس. They do that course. maybe الآن عندنا باثولوجيست وعندنا روح طيبة وكذا يتعامل الآن السيميلر فورم not necessarily 4 weeks. يبدأ دائما البنى من طوبة والآن ده ممكن يبتدي أونلاين الآن ويستراتيفاي radiologic pathologic data نجمعها و provide طبعا تكون يعني بس our own كيف نحن البلد بعيدين منها عشان نكون عندنا our own material عشان الاسمسيتي والبروتكشن اوف كده. ف the idea is needed يعني انه يكون في core common اشياء كثيره كلها بقت common knowledge الان. كل المعلومات كلها common knowledge زي ما حصل يعني انا شفت people were exercising this بالذات في الكورس السابق هنا. They were discussing يعني very much alternating يعني زي التيبل تنس بيلعبوا الباثولوجيست والراديولوجيست وكده بدون ذكر الاسماء يعني الان كانوا they were exchanging information في discussions.
Yes.
Very highly intricate discussions. I think this idea is good to have one training forum for a new generation. احنا الان كل مهمتنا انه نضع better plan for the new generation.
Yes. And that if when I should not say if when they start at a better point, not slipping back so much because of what happened. Yeah.
I see.
So I want to say something also. Nowadays, you cannot treat breast cancer if in early setting metastasis without knowing the breast biology. I wonder for those who would the chemotherapy protocol for every patient of breast cancer. This is not a good practice if you don't know at least the ER, BR, HER2 status. So without breast biology, you cannot treat breast as it is in early setting, in metastatic setting. And last ASCO, they conclude that circulating DNA, if Jihan is with us still, circulating DNA is now very important to detect treatment failure even before evident treatment failure radiologically or symptomatically. Even before this detected, circulating DNA is nowadays is jumping up.
It's a must. It's a must, yes.
Yes, they talk about this to detect the failure earlier, to
Yes.
introduce the treatment failure before any evident recurrence radiologically symptom before even. This is a very amazing in class ASCO. We cannot treat patient alone. We can't. This is for all the specialties, but I hope the practice to change in near future. You cannot treat the patient alone. We have to sit. We have to know what I want from the pathologist, what the pathologist knows from me, what will be benefit for the patient. We have to sit more. We have to discuss more.
So from here, I will invite you, and remembering you to attend the MDTs, the monthly MDTs presented by Dr. Wela and Dr. Hiba. You see, and it will be good, all of you, to attend and to make it as a need us for discussion and to go further from this point.
To build up the multidisciplinary
To build up,
practice.
to build up the bottom of our practice.
Welcome,
Yes.
welcome, Rabab.
All of us will learn from.
Yes, make
from
a
that.
reminder for us, please, Rabab,
Yes,
because
yes.
very busy time. Just make a reminder.
one last word. طالما البيولوجي ذكر الآن طبعا يعني العالم مشى إلى precision medicine
Exactly.
where they take out cells from the patient's tumor and then they cook them with these drugs that end with NAP to find the one specific
for the patient,
for this patient's particular
tumor
type of cancer, particular tumor, and then they re-inject with that, and they are getting good cure.
Yes.
Cure and not just regression.
Yes.
Similar to
إن شاء الله نحصل كده.
Similar to culture and sensitivity, Dr. Prof. Muhtasem. Similar to culture and sensitivity in microbiology.
Yes.
Exactly.
The same
practice changing, Jihan. Very practice changing, and to catch up before.
Now, precision individualized medicine.
Yes.
What is good for one patient is not good for the other.
Yeah, exactly.
Tailored for each patient.
ربنا يبارك فيكم جميعا ما شاء الله. يعني لسه كثير اتدمر لكن لسه في كثير مختزن. في كثير مختزن. It will grow 7 سنابل وفي كل سنبلة تطلع منكم 100 حبة.
يا دكتور معتصم، احنا عايزين العالم يستعيد ثقته فينا، يستعيد ثقته في بلدنا عشان يقدر يدخل، عشان نقدر يستفيد وهي يستفيد. الناس عايزة تدخل بلدنا لكن زي نقطة الرصد، زي ask always about this. كل ما نمشي مؤتمر بيسألونا عن الناحية البلد كيف عشان نقدر هل هي سيف انه تو كم تو السودان. فنحن نتمنى انه نكون نعيد الثقة في بلدنا والناس تدخل بلدنا وتعرف عندنا وكده فنحن حاليا بحس ان احنا في عزلة. نتمنى انه الناس ترجع ترجع تقدم نفسها للعالم بجد، لانه العزلة ما كويسة. العالم كله هسه بقى كولابوريتنج والناس تدي وتاخذ وهم بيستفيدوا مننا برضه. احنا برضه عندنا احنا برضه بنفيد عندنا داتا ممكن نقدمها. فأتمنى أن تكون البلد الناس تستعيد الثقة في البلد.
السيمبوزيوم اللي فات مع كنا عملنا انفيتيشن لإيجيبشيان ولعمانية وكويتية، فكانت it was good experience وكانوا هم فعلا الكومنتس very positive feedbacks. هم كانوا فعلا ما كان متوقع، هم ما كانوا متوقعين الليفل بتاعنا كسودانيين. نحن واقفين في الحتة دي، كانوا متوقعين أقل كتير جدا من الليفل اللي هم شافوه. وأنا رسلت جزء من الكومنتس بتاعتهم في الجروب لو تكوني شفتيها.
أنا في المستشفى شغالة فيها بيسألوني أنتوا أصلا عندكم بريست سنترز في السودان؟ كويتشن بزعل. أنا بزعل لما يقولوا
لا ما تزعل.
ليش؟ لأنه ده جزء من العزلة اللي بقولها لك. الناس ما عارفين they don't know what is going on.
إحنا عندنا السيرجونز اللي عندنا علموا الناس أساسا. الرويال كوليج لما بدأت تطلع سيرجونز بتاعين أونكوبلاستيك وبتاعين بريست سيرجونز، وقبل ما ذاته يبقى في سب سبيشاليزيشن. ناس نديل كانوا غايدين العالم في البريست سيرجري.
ايوه انت عارفه يا دكتوره ناديه، انا مشيت غانا قبل الحرب بسنه، المركز بتاع
دي
غانا.
دكتورة ولاء اللي بتتكلم، ما في مشكلة، دي ولاء.
دكتوره ولاء.
آه.
المركز في غانا، في كوماسي غانا، مركز في مستشفى اسمه كونفوي اونكوي تيتشنج هوسبيتال. سألوني عن سودانيز دكتور، قالوا هم اللي استابلش المركز بتاع الراديوثيرابي which is a very advanced center. حتى هو عنده collaboration مع ويل كورنيال ميديسين، لكن قالوا انه السنتر ده اللي اسسوه سودانيز. سألوني منهم بالاسم، قلت لهم unfortunately هم خارج السودان الان، لكن انا اعرف. قالوا هم اللي اسسوا اللبنه الاولى بتاعت المركز الاورام في غانا كوماسي، في كونفوي، مستشفى اسمها كونفو اونكوي تيتشنج هوسبيتال في اقصى غرب افريقيا.
وهم مشوا لقدام ونحن واقفين.
ايوه كتير، ما في مقارنه. احنا مشينا
ما دي
عشان
المشكلة
لكم
بتاعت السودان.
إذا عايزين تزيروا الأوجاع نديكم منها زيادة. أولا الويلكم
way back,
لابوراتوري
yes.
اللي كان هنا في أساس محل معمل ستاك ده والكده. they have done a great research في مجالات كثيرة جدا. طبعا لو استمعتوا لطارق الهادى وقرأتوا كتبه تلقوا فيه العجب العجاب. حتى لو تشوف الانتي بالهارزيال، ذا فيرست انتي بالهارزيال، العلامة دي أنا مصورها لو في القديمة، لو لسه المبنى ما تهدم، البلاك موجودة في الحيطة.
Yeah.
لما اكتشفوا الفيرست انتي بالهارزيال ذير، حطوا البلاك بالديت بتاعها، اظنها 19. انا عندي السلايد هنا من السلايدز بتاعتي، لكن دلوقتي ما بقدر اطلع لكم يوم ثاني. وطبعا حكينا باقي الحاجات. مستوى البراكتس يعني طبعا أنا اكبر منكم كلكم، فانا شفت المستشفيات وانا طفل.
ايوه.
المستشفيات السودانيه. وبالعكس
مستشفى
انا
الخرطوم.
وانا طفل لغايه ما مشيت الثانوي ما كنت بتعالج عند الاطباء، كنا بنتعالج، المساعد الطبي كان بيعالجنا ونبقى كويسين.
ايوه.
وفي الشفاخانه ما كنا بنمشي اسمها ايه زيتونه، ولا بنمشي وين وين كده عشان نلقى دواء كويس.
لا.
كنا في الشفاخانه في الخلا بتاع خرطقة وادي سيدنا وحنتوب وكده. we were treated.
عشان كده
يعني الوجع كثير.
يا رباب نحن ما وقفنا، نحن وقعنا.
لا ما حنجيب ان شاء الله. اهم حاجه
نحن كنا
اور هاند ناخد
في
يدينا
ستاك.
ببعض وما نجيب.
انا في ستاك كانت في حتى البروف انوار كانت متواصله، يعني هي معاها الموضوع. The family of welcome were interested in building، حتى مشوا انجلترا وقابلوا الفاميلي معاهم ناس الاثار، لانه المبنى بتاع القبه بتاعت بالناحيه هنا عندنا في ستاك، القبه دي is under protection من ال inheritance وكده. المهم فهم قالوا نحن we are ready to build a building and a big lab and a center for pathology، اللي هو يبقى زي الرئاسة بتاعت ال postgraduate degree in pathology behind القبة، معاها library، معاها connections، معاها كل حاجة. It also didn't work out because probably the government was involved.
وبرضه يا بروف نحن كنا في توبة، كان في خلاص about يعني to start، كنا preparing for women health center.
Yes.
فاكرة مش فيه OBS and gynae وبريست سيرجري وبريست وومن ايميجينج وباثولوجي، كل البرانشز ودونا البيلدينج وبدينا خلاص preparing، يعني كله البروجكت كان كله ناس بتكتب البروبوزل بتاعهم، حتى البروبوزل بتاعتنا كلها كانت جاهزة.
Yeah.
كان supported، مش كده، كان ب إيطاليان كمباني.
ايوه.
وبعد ذاك وقف مع الحرب يعني.
الحمد لله.
فنفتح يا ولاء ونادية، أظن نفتح للبارتيسيبانتس المجال لأي سؤال للمجموعة. أظن الأوجاع كفانا منها.
بالضبط.
نرجع للساينتفك. talk. إذا في حد عنده سؤال للبريزنتر.
أنا عندي أحب لكم أول سؤال. كانت عندنا مريضة جات ب recurrent breast cancer. هي over 90 وبيدياتريك consultant retired. فكانت very interesting وكانت الريكرنس اللي جاها different عن البرايمري الريسبترز والتيومر تايب. فهم اعتبروه نيو كانسر مع انه ما في بريست اساسا ولا في axillary nodes. فما كانوا يعني اخذوا carry forward عشان يعملوا decision which treatment يدوها ويعالجوها كيف. فيا ريت مستر حسين يدينا الانسايت بتاعته عن الكيس دي specifically إذا عنده خبرة عنها.
Thank you so much. So what is the time span between the primary and the metastasis?
Over 20 years.
Over 20 years. So ideally, to rule out discordance, you need a fresh tissue diagnosis. So if it is amenable for any kind of image-guided or surgical biopsies, that should be ideal. However, in a 90-year-old lady, I wouldn't think she is sparkling and very fit. So anyway, if you can't find any way to have a fresh tissue diagnosis, you go back to the primary, and if it is ER positive, you assume it is the same. It is distant recurrence. It is metastasis. It is not a new second primary. And then if you can't diagnose, you just carry on. Because she is 90, you can put her on AI plus bisphosphonate plus or minus CDK inhibitor if there is any evidence of progression later.
We already did the biopsy and I don't remember the tissue type, but I remember I discussed the case where we had the course and the receptors. So
Okay.
the oncologist was querying, is this recurrence or?
It is a recurrence, even if
even
this
if
is a
different.
Yeah, even if it is, because if it is a second primary, it should be in the breast. Because
even what? Again?
So she had treatment for one breast, am I right?
Yes. It is in the same mastectomy site.
Yeah.
So the recurrence was in the mastectomy site?
Yes, in the chest wall, axillary tail, I think, or axilla.
Yeah, it is not a second primary because theoretically there is no breast anymore, just few cells left in the flap. If it is another cancer, even if it is discordant, it is a locoregional metastasis or locoregional recurrence. It should be stage R to make sure that there is no metastasis elsewhere. And if there isn't, then you treat her either with local excision plus or minus radiotherapy if she hasn't got radiotherapy in the past, and then send her back to the MDT to discuss what other treatment they can give.
So yeah, if she has previous, so it was not the radiation sarcoma. This is a differential diagnosis.
No, it is a breast cancer.
No, it was breast cancer.
Breast cancer, not sarcoma.
Cancer,
okay.
Yeah, but if she had a mastectomy in the past without radiotherapy, now you have the chance to do radiotherapy. But we don't do radiotherapy twice. Although recently people are starting to do another dose of radiotherapy, even if she previously got radiotherapy, provided that it's at least 10 years ago. But it is not the standard of treatment. We don't give radiotherapy twice.
Okay.
Thank you. Yes, but that's why we said that every recurrence we must do hormonal assay for the patient in every recurrence.
Yep.
And treat accordingly.
Yep.
Yes.
Because the patient benefits from hormonal treatment, yeah?
Because you, in 90 years, I would try my best not to give chemotherapy.
Hormonal.
Yeah.
But other modalities of treatment like endocrine therapy and other modalities of treatment.
Yeah.
I don't understand your point, Jihan. What did you say?
Is 90. If you can't give endocrine treatment for any reason, you can consider surgery, you can consider local radiotherapy, you can consider monotherapy, not like a full cycle of chemotherapy, because you need to be
You are trying to avoid chemotherapy for her age.
Yeah, she's 90.
Okay.
Yeah,
Okay.
I wouldn't.
I understand the
follow-
point.
Yeah, exactly.
Okay. Thank you.
Any
You're
more
welcome.
question?
Okay.
Or comment?
Thank you so much. See you
Dr.
next
Amin
time.
was there. Dr. Amin, are you there? Still?
السلام عليكم.
وعليكم السلام.
والله أنا آسف معليش أنا والله I'm traveling عرفت كيف يعني أنا just arrive المدينة أنا جاي من جدة والله.
ما شاء الله.
كان عندنا ميتنج هناك فعشان كذا ما قدرت لكن استمتعت بالميتنج وأنا في القطار. يعني thank you so much for this actually these are excellent presentations يعني really وأنا am really happy to be with you يعني وإن شاء الله to participate in the coming webinars يعني إن شاء الله نكون معاكم في الجايات
إن شاء الله.
قاعدين في أي وقت يعني إن شاء الله
If you want to add anything, would you like to add anything?
والله أبدا دكتورة رحاب ما قصرت من ناحية الأونكولوجي يعني she presented very nicely. Now there is nothing to add more. لكن ان شاء الله اكون معاكم انا والله الى الان ما يعني دابي وصلت محطه القطار منتظر سياره اطلع على البيت فان شاء الله في الميتنجز الجايه الويبينارز الجايه ان شاء الله باذن الله اكون معاكم يا دكتوره رباب. Thank you so much.
إن شاء الله. Thank you for your participation. Thank you very much.
الحمد لله على السلامة.
الله
الحمد لله على السلامة.
الله يسلمك.
So I will present the last thing. So once again, our sincere thanks to Dr. Rehab Abdullah Usman Ahmed for that excellent presentation and updates and for sharing her experience on treatments of metastatic breast cancer. So, and thank you for all our speakers and participants for making this event so engaging and insightful. As we come to the conclusion of today's session, it's my great honor to invite our chairman, Dr. Rabab Bella, to share her warm closing remarks. Dr. Rabab, guidance and dedication to the society continue to inspire us all, and we are grateful to her leadership and vision. Please join us and welcome Dr. Rehab. Thank you very much. The mic is yours.
Thank you, Ella, for this nice introduction. Okay, I would like to extend my sincere thanks to our distinguished speakers today, Prof. Muhammad Al-Mu'tasim Al-Balbagi, our teacher, our professor, and our mentor, Dr. Jihan Ahmed Ibrahim, Dr. Hussein Ali, Dr. Rahab Abdullah Usman Ahmed. Thank you for your generous time, knowledge, and the clarity you brought to such an important subject. To everyone attending, our engagement keeps SSBIWH active and strong. October has been a powerful month for us. We successfully delivered a series of activities across Sudan, including awareness campaigns, in hospitals and communities, imaging education sessions, pathology and tumor board collaborations, and continuous support to women who face breast cancer in difficult circumstances. We learned, we advocated, and we strengthened professional networks. Most importantly, we reminded women that early detection can save lives, even when systems are strained. Our mission does not end with October. We carry this momentum forward into every month. Education, awareness, research, and unity are our tools. Sudanese women deserve the best care, and we will continue working together to make that a reality. Before we close the month, we are pleased to invite you to our final breast cancer awareness webinar this Friday, 31 of October. It will be held online in collaboration with Bashir Hospital as part of their October activities and will be presented by Dr. Rabab Bella, myself, on radiology overview of breast cancer. Details will be shared very soon, and we look forward for your participation. Thank you again, and I hope to see all of you in our upcoming events and initiatives. Please keep supporting SSBIWH and
Thank you.
speaking knowledge within your teams and communities. Have a wonderful evening. Thank you very much.
Thank
Thank you,
you.
Rabab.
Again
Thank
and
you.
again.
Bye-bye.
Assalamu alaikum.
Thank
Salam
you.
alaikum.
عليكم السلام.
Thank you.
سلام.
Thank you.
مع السلامة يا خواجة. مع السلامة.
Assalamu alaikum, Prof.
الله
عليكم
يحفظك.
السلام.
Thank
Last
you very much.
ربنا يحفظكم يا بناتنا ويوفقكم زيادة.
آمين آمين يا
ويحفظكم
رب.
شكرا يا
جميعا.
يا بروف، شكرا.
شكرا يا بروف for your
شكرا
support,
جزيلا.
Great
for your
pleasure والله. Great
everything.
pleasure.
عاجزين عن الشكر والله،
لا
عاجزين
ولا شيء.
جدا عن الشكر.
شكرا
Great
جدا.
pleasure وواجب كمان. نادية keep well. Okay.
مع السلامة.